All right, y'all. Welcome back to another episode. Thank you for joining us here at Sin Dieta. Just a quick reminder, my name is Christina. I use she, her pronouns, and I am a registered dietitian. I don't know who wants to jump in next.
My name's Nicolette. I use she, her pronouns, and I'm a medical provider.
Bingo, I'm Stacey Ray, she, her pronouns, and I'm a licensed marriage and family therapist.
Veronica, I use she, her, and Aya, and I am a therapist, ACSW here in California.
Perfect. All right. So today we wanted to present a case study that we came up with to hopefully help provide some context on how we would approach a client coming to us for support, what kind of thoughts come up for us, and just kind of navigating step by step what this looks like, how it starts, how it develops, and all of the little details in between. So, next slide. Quick little disclaimer that we can just kind of get out the way real quick. This podcast is for informational purposes only, and it does not constitute any medical, nutritional, legal, or any other professional advice. The content is not intended to replace professional advice, and it is recommended that you do seek somebody qualified if you do have any concerns. Listener discretion is advised for younger listeners, and the views and opinions that are expressed are those of the host and any guests that we have, and they do not reflect those of any employer, organization, or sponsor. Next. All right. Real quick before we get into the meat and potatoes of it, a few keywords to help us kind of as we start listening to some things that come up. We wanted to make sure we defined some important things that stood out for us. So, as far as some diagnoses, we are going to be dealing with OSFED, and that stands for Other Specified Feeding or Eating Disorder, and it describes eating problems that look similar to disorders like anorexia, bulimia, or binge eating, but they don't fit every diagnostic rule. And people with OSFED may struggle with difficult thoughts and behaviors around food, eating, body image, all of these which can create real emotional distress and interfere with daily life. Another section that came up for us was making sure we defined scarcity and shame. So when it comes to scarcity, that's really dealing with when people don't have enough resources, opportunities, or support to meet their basic needs, often because of systemic barriers. And shame really deals with a painful feeling of believing someone is wrong with something is wrong with who you are, often shaped by cultural expectations, stigma, or experiences of judgment. And then intersectionality was our final keyword here, where it is the idea that people's identities such as race, gender, culture, class, and immigration status overlap and shape their experiences of privilege, discrimination, and access to resources.
Thanks for all that intro, Christina. I know it's a lot of definitions. Everyone can always refer back to the slide too. Yeah, I'm happy to introduce the case study here. And kind of pretending this is a client who this is a case that I know we had kind of come together based on aspects of other cases that we have seen in real life. So for this is a young Latin cisgender female who presents for concerns and challenges with restrictive eating patterns, needing nutritional support, and what we call rehabilitation, like having to renew and restart how to eat regularly in a healthy, overall well-being way. She struggles with body image and for a long time has had concerns about fear of weight gain. I guess I'm adding more family context there too, right? With a family with her background, she's always been told about that she's been bigger at a bigger weight. It's a lot of messaging within her circle and outside, and as we know, just in society. So these challenges have been for lifelong for her. She works at a restaurant and she works there for herself, but also to support and provide for her family who she lives with still. She's the oldest sibling of a few other younger siblings. So she's always grown up being the second mom or mama and taking care of them in a very wide range of multi-generation household. struggled with these experiences for about 4 to 5 years. This is her first treatment attempt reaching out for support. Other challenges that she's experienced her whole life include depression, adjustment disorder into different phases of lives and stressors that have come up. And so remember, kind of note to highlight with this example, so with what we've shared so far, are those keywords that Christina shared, right? The scarcity, shame, intersectionality. What stands out to you when you're hearing this story? So yeah, next slide. Let's see. So just more specifically with some of the behaviors, kind of pretending we're asking what's going on. Shares that currently she barely eats anything because of the eating disorder, but also there are times she barely eats because of food insecurity, whether it's just because of not having enough money as a family, or there are some SNAP benefits, but that has been a recent challenge for her to afford food. So there are two reasons at times, whether they're at the same day or different days, that lead to eating very low amount of calories, as you see, 800 to 1200 a day. Actively calorie counting. There have historically and currently been moments where there are binge eating episodes where she's eating more to the point of feeling really, really uncomfortable. And whatever food she has at home or foods that are from the restaurant. There historically, not currently, has been some episodes of self-induced vomiting, which is a form of purging, and really tries to focus on low-calorie drinks as well, whether it's diet sodas or waters, but also doesn't have much of that during the day. Really puts a lot of categorizations, like labels on foods, safe or unsafe. And as I mentioned before, that recently, due to recent circumstances, she's experienced some decrease in SNAP benefits, or her family has. So the amount per month has been much less, even though, as we all know, the cost of food has increased. Has expressed a lot of stressors with the community and ICE and safety for her family members, and just their security overall. So there has been a lot amped up for her emotionally recently. So with all of that, there's still a lot of loudness from the eating disorder, feeling a lot of guilt when it comes to food and having access to food. Sometimes with work, she works at a restaurant, she will bring the food, but maybe doesn't eat it. She may share it with her family instead, or sometimes will avoid eating at work overall, even though she does get a free meal through them. And like I said, I think the biggest thing, even when there are so many big stressors and worries in her circle and her community, she's also still really worried about weight gain and where her weight is going. So she's trying to balance a lot right now. Yeah, I think that's the main thing. I know this is a good point to see what other information we all would want to know and how to best support her from our avenues. And is there anything that you all are thinking about right now that would want to ask or learn more about with this case?
I think just kind of, I'm going to jump in here, but I think just hearing, right, this case study and the presenting problems, like what comes up for me as a provider and as just a individual is this story probably reflects a lot of people's stories right now, right? Especially taking into account that she is from a multi-gen household, right? There sounds like there's a lot of responsibilities that fall on her, and maybe she's not able to kind of really focus on taking care of herself first, right? And putting her family and others before her. So that's kind of what's coming out for me. I definitely am curious to see just kind of or learn a little bit more about like her motivation as to like why now, right? Like why is she kind of reaching out now versus before? And then just kind of tapping into, it sounds like she's been having some of these behaviors for like the last 4 to 5 years. So that's kind of where my curiosities go. But I want to see what everyone else thinks.
I can jump in as well. I think when we like get cases, or like again, obviously this is like a faux case, like it's not a real one. But like when we're thinking of as practitioners, I think we talked a little bit about this before as we were prepping of like how is she coming? Like Veronica said, like, well, why now? But it's also too like I'm always curious of like how did they get here? So whether it's through their dietitian, through their doctor, through a friend, through a referral, like how are they coming in what realm? Because I think it sometimes will give us information of like what they saw that the problem was, or if they didn't see that there was a problem, but somebody else was like, hey, you might need to go talk to somebody, so that to kind of really understand like maybe how much or how little they really know about what's going on. Like the case study said, this person doesn't have any history of eating disorder treatment, and so someone who doesn't have a history of eating disorder treatment might not really understand anything about eating disorders, or might maybe know and like not know like you could have a full team, which is why we're all kind of here presenting of like if you actually had a full team, what that would look like when we focus on disordered eating behaviors, regardless if this person had a diagnosable eating disorder or not. Obviously that they do, but like when someone has eating disorder issues, how we all kind of focus on it in different ways, and how we sometimes obviously they only have one of us, right? They'll only have a therapist, a dietitian, an MD, or a psych, or even just a GI, right? They're going in because they're having stomach issues, but really being able to go through all of us and see, like, I'm always curious. I'm like, how did you find me? And they're like, oh, well, my dietitian. Then I'm like, oh, you already have a knowing that what's going on. But usually sometimes when it's like the MD or like, a GI or something like that, I'm like, oh, they might have a little bit less understanding because their labs might have clicked off, right? Or their weight might have clicked off. Or those are my assumptions at least of what kind of happens. But yeah, I always am curious about those pieces of how they get to us by like what means.
Yeah, I think with that too, I think it's really helpful to also really pull in a little more about like what their own goals are. Like
Mhm.
after establishing, hey, like how did we end up here? What's going on? How are you assessing your current situation right now? Do you perceive an issue going on? Is this coming from external resources that are telling you, hey, we need some additional support? It's also like, hey, I'm gonna have my recommendations for you, but let's just start off with what do you want to accomplish? And if they don't have goals because they're like, I don't know what's going on, I'm like, it's okay. That is a dynamic piece that is going to continue to evolve along this process. And if we started with nothing, we may likely be able to pull something later on. And whatever we started with as you advance will likely also change depending on the progress that we're seeing. So that too, and I think like Stacey was saying, because we don't you traditionally see everybody has like a fully assembled team. It really is if they are needing additional providers to have that more holistic care being provided, being able to have like clear collaboration between them so that everybody feels supported. Because I think a lot of the times there are going to be some that maybe feel overlooked or like what is the word, like not taken as seriously, especially when they're coming from like the medical world and a doctor like referred them. They're like, okay, this is my patient. I'm like handing off to you. This is what I think they need to do. And when you come back with them with your recommendations, they're like, wait, I have to like kind of like set your case and state why you think this is important. But I think keeping the client at the center of this is why I'm thinking this and involving them in the thought process really helps to hopefully establish that trust and like continued collaboration within their own support.
Yeah, good points with the collaboration. As I was sharing all this, but I was trying to put myself in the shoes if I was in a regular primary care setting. And I just can't help but feel kind of concerned of this could easily just be missed. A lot of these things may not have been shared if it was a medical visit, unless it was a visit for depression and maybe interest in medications, or if they're like you mentioned, Stacey, stomach issues that maybe arise. But I even with that thinking a lot of the times asking about access to food, income, all the things that we're sharing here, like they don't generally get asked. They may just be very, very narrow tunnel vision focused onto what the symptom is and what they're here for this 15, 20-minute visit in the medical world. So Yeah, I don't know. I share that just because I feel like there's a lot that can be missed. When it's not missed, it would just be a direct referral, I think, from my experience at least, to a therapist. And then maybe that's where more can be deeply dived and brought out. Um, on the other end of things, if you are a med provider who specializes in this type of care and you were referred to someone to be part of this team, kind of like we are pretending to be here, they then are probably more able to know, like, hey, this is what I need to check to make sure you're safe. Let's also check in on some agreed upon goals that you're here for, what motivated you. A lot of the times I know with clients I work with, they actually don't really know what they need medically. They really just want help with the mental health piece or nutritional piece or how to balance that without still gaining weight. So a lot of the times medically, I've had to give ideas of, well, these are some common goals or challenges that other folks face. I don't know if these resonate with you, and there are things that we can focus on. Maybe gastric bloating, digestive issues that are triggering. Maybe it is that fatigue and you're concerned about your thyroid. We can definitely check that. So sometimes it is helpful to ask what they come in with, what they know they want help with, but also giving ideas and examples too. And then most importantly too, after all this, it's communication with the rest of the team members. So we're all on the same page. We all have the same information and understanding. I know some things that don't always get asked too is just, yeah, are you struggling right now with having enough food? Are you struggling with consistency of that? Are you providing for your whole family? So yeah, this information, this example is just so important too, to know how we navigate their recovery in a realistic way that resonates with them and that works with them too. Yeah.
I want to jump in real quick and just, I think, highlighting how important that care coordination piece is between like all providers that are going to be doing the work for the patient or with the patient, right? Especially when I think of, like other outpatient programs that maybe only provide like a therapist or maybe it's only like a dietitian, right? And then you kind of have to go to all these different places to be able to have the other professions like kind of come in and work with you. Like that care coordination is so important because the last thing we want is for our patients to feel like fatigued from having to repeat, right? Like their stories over and over again. Like that's something that I've seen, right? Like pretty constantly, like and in our line of like work, right? Where they're kind of like again, like I have to like repeat everything and answer questions and just being able to again like really focus on that care coordination piece. It's so important. But then just kind of also taking that wider lens stance versus kind of that narrow, just kind of like what is happening like right now, but taking your time, I think, as a provider to see like the larger picture, right? Like, of like, what does your family look like, right? What kind of supports do you have? Who knows about this? Who doesn't know about this, right? That's really important, especially when it comes to even for this patient, just seeing that some of these factors, like there's a lot of intersectionality going on with the barriers that are happening. Some of them are really out of her control, right? So it's really important to be able to have that like wider lens perspective versus just kind of that narrow, like this is what's going on view, because that's when things get missed, unfortunately. And then with like OSFED, I could see like a medical provider that's like outside, not eating disorder related, not taking someone with OSFED seriously because they're not fitting into like a box. And
Yeah.
we see that a lot with OSFED, unfortunately, right? There's someone with a bigger body who's still restricting, and they're kind of like, "No, you're fine." But it's kind of
Right.
going back to a lot of like those stigmas, right? Even culturally, right? I think of it, and I'm just kind of like, people probably again judge by the basis of like how our bodies look versus the behaviors that are being done, which is really damaging. But my 2 cents.
Mhm.
And I'm not sure which is the next slide, so I don't know how, like, what if we should go to the next one or if we're jumping in still for like now what we would do as clinicians. What do you guys want to do?
Good point. I can share what I would do since I kind of
Okay.
presented.
Yeah. I didn't know what the next slide was, so I didn't know if we were waiting.
Yeah, no, because I was thinking about this. I mean, myself with my experience and taking every eating disorder as seriously as it deserves, I think I already know I would be checking just general medical workup. So that involves, how vital signs, blood pressure, heart rate, how they look when someone is laying down and standing, because that tells us a lot about their body's efforts that it has to put forth against gravity. Lab work to check an array of things, right? Hormones, electrolytes, how your organs are working. Are you anemic, or are you deficient in a lot of nutrients, right? Again, no matter what the picture looks like or the diagnosis, if there's a lot of restriction and maybe binge eating, purging like that, internally you can't see those, or externally you can't see those things, but internally there could be a lot there that could be concerning. I have had cases similar to this where I've had caught abnormalities that were really concerning for me with their electrolytes that I had to then check repeatedly, even if their weight was the same, or there were days they did eat okay, but the days that they didn't or had difficulties, it really impacted their body. So I think just coming from my own experience, and that I know I want to let them know that I take it seriously. I want to work with them if they aren't sure if that's really needed, and educate them. And of course, make it in a very trauma informed way to know, like, this is what I would recommend to make sure they're okay. And just checking head to toe issues. Are you struggling with the digestion? Are you struggling with sleep? How's your mood, anxiety? So pretty getting thorough with that piece. I know some of those questions overlap too with what a therapist would ask and a dietitian would ask, but I think it's totally fine to ask some things repeatedly if it's just a small few list of questions. But yeah, I think it's a very general kind of workup. I have given guidance to other providers who do not have experience in this field to know, like, hey, these are some common issues that can happen that, again, you may not notice based on weight or weight trends, that still should warrant a checkup for this client. So yeah, that's kind of a general sense of what I would do. If it's virtual, I can examine them based on how they're acting, but I think important data is more through blood work, vitals, and what they're telling me directly too.
Yeah, I think with some of the overlaps that we have, I really like how you said it's okay to ask the same thing, because I feel like even if it's the same thing, we're probably going to word it differently. And because they know they're seeing someone differently, something else may come up. They might answer it different, provide different information, and then we get that much closer to a fuller picture when we bring all of those pieces together. So I think with adding to some of what you would really focus on, Nico, I think I would also expand to like really getting a strong background on like anything they were willing to share related to their relationship to food, right? Like what was their earliest memories of how it was introduced? Do they remember any familial rituals or cultural expectations, or are there any like religious aspects to it? Did parents or whoever the caregivers were model food in a way that had certain unintended restrictions baked in that they from there I think maybe took on as this is the way that it needs to be? And then after that, how did it evolve for them as they got older, when we start to gain more autonomy and we start to interpret these things for ourselves? A lot of the times we get into like, I don't know, that middle school and beyond age where our parents aren't, making food for us as much anymore. And it's like either grab what you can, or maybe if we have like, free lunch access, we're eating whatever's at school. And sometimes we're not eating because we're so busy with school activities. Who knows? We probably go 8 hours of the school day and don't eat until we get home again. So how does that impact our ability to focus, to be academically, present, and how do we translate that into, I don't know, perceived worth and all of these other things that can really feed back into the problem that we're trying to help them unpack?
I can jump in. So kind of what I said before, I would first definitely assess like who's the referral. Like, how did they get to me? Gives me a sense of like maybe how aware they are, because like obviously this is a not real person, so not really knowing how much they know. Like at times she barely eats anything due to eating disorder, but does she know that she has an eating disorder? Because I think a lot of the times, especially in the Latina population, it's not talked about, so they don't really know certain symptoms are associated with eating disorders, right? They're just like, oh, I just have a little stomach issue, or like, oh, my hair's just falling out, or like, oh, like I just don't eat those things because they don't, my parent says they're not good for you. So really having to try to go slowly and not like, dunk their head underwater of like, hey, you have an eating disorder, but really asking them why they came to me, like why me particularly. This is like for all my clients, but like why did you choose me? What about my profile or what someone told you had you choose me? So then I can kind of really assess like the level of understanding they have of their eating disorder slash disordered eating behavior, especially when it's something like OSFED. And OSFED is basically anorexia without the BMI section, right? And so, especially if they're so conditioned to like, oh, I only have anorexia if I look like X, Y, or Z, then we might have to do a little bit more psychoeducation, even just like at the front of it, right? Because they might just be like, oh no, that's not what I have. Like, I must not have that because of how I look. And so I think when it comes to assessing, it's really asking them first before we go too far into the BPS or I'll send them an intake form. Um, I'll have the intake form. If I don't can't tell if they know that they have an eating disorder, I won't add the food behavior list, because usually I have like on my intake, it's kind of like BPS or the biopsychosocial. So it's like your name, your behaviors, your past history, your mental health, your support system, stuff like that. And then the last page is usually like eating disorder behaviors that all the ones I can think of. But I usually will withhold putting that until I know that they have somewhat of an understanding of what if they have an eating disorder. Because if they have disordered eating, I think a lot of the time in the BIPOC population or not, it could scare them away because they don't want to be understandably like like labeled with a diagnosis, because that's that can bring, like we said earlier, a lot of shame and feelings about that, or just I think distrust of the system at whole. And so wanting to make sure that the goals that they have for me are goals that I'm good to work on, but also them understanding. Like I had a client come to me because she saw that I was an eating disorder therapist, but that she came to me for weight loss. And so having to have, if I think that would have been like, here's your eating disorder inventory, she would have been like, I don't have an eating disorder, I just want to lose weight. Right. So being able to like pull that from the intake and really just like actually have conversations with her of like, what are you wanting to do? And so when she said weight loss, it's like, okay, like, well, what about weight loss? Like, why do you want to achieve that? Really like almost acting like I was like 5. Like, why would you want to do that? Like, what about that feels necessary for you? And then that intake might have taken more than one session, right? Where it's like, I'm going to slowly do this because I'm not going to just, at least for me, I'm not going to just be like, oh, no, I don't do that. Right. But like, because like we do take clients who want to lose weight all the time. They just might not tell us that's their goal, but we take clients like that all the time, right? So having to kind of like, I think, especially in like more formalized treatment, they get a little like, well, that's not what we're here for. It's like, well, no, we actually are. They just said it. They just said it out loud. And so really wanting to make sure the client really understands like the why behind the weight loss, and then kind of go, and then everything I think in terms of treatment plan and going forward in sessions starts from there. But that's kind of like how I do my intakes, because I get a lot of like eating disorder adjacent. So it's either like they had one and now they're like on to a different phase of their life, or they're like they have one but they really want to work on this, but clearly they came to me because they had some type of food issue. So I tread lightly.
I think that's a really good one. And it makes me think of how a lot of the times when they do finally disclose, they're like, okay, I'm here for weight loss. And like as a dietitian, they'll tell me like, you're gonna help me with a meal plan, right? And I'm like, well, let's talk about that, because full disclosure, I'm not gonna give you a meal plan that puts you on a diet that is limiting you, but I am more than happy to welcome these conversations because I want to make sure we are removing the shame and the guilt and the like, taboo. I want to achieve weight loss because the world tells me to, but all of a sudden I'm not allowed to talk about it because it's maybe making me a quote unquote bad person. Like, no, tell me why so that we can talk about potentially what are these goals that you have for yourself that could actually be achieved in different ways that have nothing to do with changing your body.
Yeah, and I think to give credit to like all eating disorder, like medical, like dietitians, doctors, NPs, all of it, it's like you guys are way more well-rounded in education than most doctors or most like medical staff because you understand why jumping to weight loss can't just be the recommendation, right? So you're having to actually go way slower and understand, not just from obviously your point of view, but the client's point of view. I think of y'all as like the myth busters, where it's like a client's come in, it's like, I'm addicted to sugar. Or I think, I'm having some inflammation and I think I think I'm celiac, right? Or I'm bloating. Like, bitch, all women bloat. Right? Like, but they're told like, oh, bloating is an indication. Obviously, there's like versions of this, right? But like bloating is an indication that like digestion, but it also can like bloating could just be an indication of digestion. Maybe you have a little gas. We all do, but like, what do you do with that, right? Like, why is it an issue, and who told you that it was an issue, right? So I think of y'all very much as like the mythbusters when clients come in like, I want to lose weight. It's like, okay, well, why? It's like, well, because I'm addicted to sugar, or like, oh, I eat too many, I'm overeating this way. It's like, okay, well, like, let's go over why we're like, lead me through a day. They're like, well, I add like, I have like my toast and my fruit in the morning, but then I'm really busy. And then like 4 or 5 o'clock comes around and I just like binge. It's like, right. And then I think that's when you get like, I always appreciate when you guys like use that as and you're like, let me just have them tell me they do a binge restrict cycle before I jump in, right? Because that's, most eating disorders have something to do with restriction. They're just different. Like even like binge eating disorder, it's like restriction comes first majority of the time,
Mm-hmm.
and then we're jumping to
Thank
binging.
you.
Yeah,
Yes.
you're welcome. Go for it.
You cannot convince me that binge eating is not a restrictive eating disorder. Like, where did it come from, right? We are restricting, limiting, giving ourselves some rule in some form or fashion, even if you think you're like eating regularly. Like, you have a rule that's telling you, I can't do this or I can do it if there's a condition attached to it, it is not eating freely with permission.
Why it's not kosher to say this, but why I question why medication treatments that are first, cleared by FDA for binge eating to be a stimulant that blocks and decreases your appetite. I can see how some folks will say that has helped them, but on the most part, I've experienced it just worsens it, just because they're restricting still.
Right. You're turning off the natural cues that are like, yo, you need to eat, because they're not doing informed
Same.
assessments.
Same.
Right.
Yeah.
They're not doing informed assessments to check, oh, you're binging. Oh, that sounds bad. Versus like, wait, you haven't eaten since 8 a.m. regularly?
Right. No, let's give a stimulant to that still, because that's going to make it better.
As someone who, like, I love working with binge eating disorder patients, because when that light switch goes on and they're like, oh, when we introduce like regular eating in intervals, and just hearing them be like, I haven't binged, I'm just kind of like, oh, fabulous. Well, tell me how, like, and why. And then that's usually when I bring out like the binge restrict cycle of like, look at this, right? Because I'm going to tap back into what you said, Christina, right? Binge eating disorder does fall under that category of restriction, because the binge restrict cycle, it's in the name, right? Just because maybe I don't know, they're not focused on like restricting like certain, and this is different for everybody, right? Because different binge eating disorders appear differently, but maybe for a specific person, maybe it's not that they're eliminating or restricting like, themselves from a certain item or food category. It could be that they are going so long without eating because they're just so busy and not prioritizing that fuel that it's happening. And then to kind of tap into like the medications, I've had a lot of people, a lot of patients be like, well, what do you think? And I'm just kind of like, let's think of sustainability. Are we going right? Because that's where my mind goes to always as like the foundation when I'm working with binge eating disorder patients or OSFED or everyone, right? I'm just kind of like, let's think of the foundational piece of recovery. Do we want something that's going to be quick and not sustainable and kind of have us go back into the cycle of, right, the disorder, or do we want something that's going to create that lasting, right, road of recovery and hopefully overall recovery for yourself, right? And with the medications going on, yeah, cool, stops your food noise or whatever they call it, but it's like, in the long run it's still there, right? Because if we're to stop that medication, what's going to happen? It's going to return probably a lot more stronger than before because your gut's going to be awake and it's going to be like, feed me, hello, right? And then we're going to be back to square one.
Yeah, and I think when we talk about like all of these like early on sessions or like intake sessions or whatever, it's like I as we all know, like actually truly letting the client share what they feel like is the problem before we diagnose, right? Like understanding what the food
Yes.
day looks like, understanding that like, yeah, like you might not be restricting intentionally, but you're restricting because you have overworked your schedule, right? Or you've overbooked yourself or whatnot, and really having to make sure, I think different than if you're just doing like a quick weight loss recommendation,
Mm-hmm.
it takes a lot longer to actually create trust with the client. Because what the client wants and what the client needs sometimes is different things. And so the client might coming in wanting weight loss, but really needs to have just a better, like a more like I always think of like informed consent. You can still lose weight and you can still do what you want, but like let's be informed about what that actually means and what your actual problems are. Do what you want with it, but at least let's get to a place where we are more informed about our behavior so you at least know that this is a pattern. You at least know on the days where you did overbook yourself, you probably are going to use the behavior at the end of the day because you're so hungry. So
Mm-hmm.
then this is where I think harm reduction comes in. It's like, so then how do we maybe prep for that? Like, how do we just give you different types of snacks throughout the day or making sure like at least when you have food at home, it's food that you are easily digested, right? It's maybe like a smoothie or not a smoothie, but like a shake, like a protein shake. Like that's going to be easier to digest. It's going to fill you up quicker because you're able to like drink it on, say if you're, I don't know what someone is doing all day. Like say you're an actual doctor who's in surgery for 12 hours. You're not taking a break to eat at lunchtime. You are doing the whole thing and then you kind of crash out, I'm assuming at the end. So how do we help that? Like I always think of like how do we help that person? Because there is a way to help them. Opposed to, well, you just need to take a break. That's not possible, right? And you don't have to be a doctor, you can just be like a parent and not be able to stop. But I think really building the trust in those first couple sessions to make sure we're um not that anyone said this is more so just like reiterating to people who are listening, like making sure that like we're not putting our agenda on the client and that the client is really feeling like the team is working um with them and understanding them, even if we obviously like we don't agree necessarily that we don't want them to be on a weight loss plan, right? That's not what we want for them. We want them to really understand and work on these other behaviors, but ultimately like really going slow, I think, rather than, I think people who are not in this realm will just prescribe the weight loss and be done with it. Prescribe the medications or the weight loss plan or whatever, and then just be done with it.
Yeah. This makes me think about what drives their motivation to come, but then to keep them coming, or even just their engagement in the middle of the session. Because sometimes we can lose them, right? If we're kind of talking about our perspective about the issue, and then maybe they checked out already and we've lost them, right? So I'm thinking for this case too, like what if their intention and worry isn't really about their fear of weight gain or the restrictive eating? They don't really want to change that, but their worry is the binge eating that happens on and off. All right, that's what they want to focus on. And that's okay to keep checking in on that. And there's
Yeah.
so much power in asking about their story. Like, what is a typical day like for them? And I think we can get so much from that by hearing their story rather than our checklist questions too, right? So yeah.
Well, especially like I've had clients who've come to me and they were in bigger bodies and went to like a, like a traditional treatment center. And to like Nico's point, the person, whoever, what person was on their team, I'll just say caretaker person, assumed that they wanted to lose weight.
Mm,
And how shitty to be
yeah.
also in a bigger body and then be like, oh, so, just to come in with that belief. And they're like, no, I just don't want to like binge at the end of the day. And now you've given them this, this other thing where it's like, no, let them lead you to the problem. Let them lead you to the problem. So you don't
That's
stick your
hard.
foot in your mouth.
Yeah.
Right.
And
Because
it's
there's
hard
a
to
whole
that.
thing about that too. Yeah. But I
Yeah.
remember hearing that and I was like, and I've heard that a couple times where they'll go into like formal eating disorder treatment. And I can like understand because that's like the diagnosis that they'd come in with like fear of weight gain. But they're like, I didn't say that. And you're like, oh,
Yeah.
well, someone put that down for you.
Yeah.
But like, yeah, how important it is to really just listen to what the client is actually saying and actually experiencing, especially someone, yeah, again, for this case study, having no prior eating disorder experience or eating disorder treatment experience. And like maybe not even like obviously we wrote it out like restrictive days or intermittent binge episodes. Like the client typically isn't coming to us with this language, right? They're describing it to us, and then we're like,
Right.
clinicalizing it. That's just the word I made up, but making it sound more clinical. Um, but like they're not talking like this to us, right? And so we're having to, figure out why they want to do what they're doing, or why they do why they are doing what they're doing, and why potentially they want to stop parts of it, because they might not even understand that safe foods and unsafe foods has anything to do with X, Y, or Z, right? They just might be like, well, I just feel more comfortable eating those foods, opposed to like, oh, I actually avoid them because I remember my parent used to always say that growing up, that like, don't eat that food, like that's bad for you. So they may not even understand what the bad part meant. They just know they shouldn't eat it.
Right. Or like with the binge eating, like, oh, how does that tie with me not eating much all day or choosing to skip? Like, just can't assume those things.
I think it's like a learning process both ways, right? As providers, as clinicians, we're learning what they are seeing, right? And what they're coming with. And then we are providing, right, that opportunity for them to be able to like identify like, oh, this is what, intermittent binge eating episode looks like, right? Or things like that. So it's like a learning process both ways, definitely. And then again, just tapping back into, right, Nico, how you were saying like the storytelling, like there's a lot of power in storytelling, right? And allowing them, as we're getting to know them, especially like in the beginning sessions, to be able to say their story and for us to hear, because at the end of the day they are the ones, the professionals of their behaviors, of what they're experiencing, of what they're going on, right? So it's a partnership, but we're never, and this I'm probably like generalizing, but like it, as providers, like we should never make our patients feel like they don't know what they're talking about, right? We should always give them that realization that they're the expert of what they're experiencing, because they are. And then we're just really there to be that partner for them, to walk them through the journey.
Yeah.
I'm like rereading the actual like the case study, and I think to the part that when I get a new client, it's like making sure if I'm not informed about something, I need to be asking people, right? So like I know this client, the case study is like the family relies heavily on SNAP benefits for food security, right? Even though I know that might not necessarily be my full jurisdiction, right? Like I put that off to the dietitian, or I think like social working licensures have a little bit more like they just get trained more on community resources like that, not LMFTs as much, which is kind of silly. But making sure I'm really equipped to handle it, and it doesn't necessarily mean to be like, I don't need to exactly know how to do all of the things, but at least need to know enough to know how I work with the dietitian and the dietitian or whoever they're working with, to really understand like, okay, what do I need to know about that affects their mental health care. So like in the study, and I know we'll talk about this as we're kind of going in the phases, but like initially it's like, well, yeah, how does that already affect anxiety? Or does that affect anxiety, right? Are they like, no, we've been on SNAP benefits since I was a kid, so like we're good with it. We've always been on it. Yes, there's a decrease now, but like I'm working now, so we're good. Or like what that means for them, and if that like is it indicative to me there's maybe other social services that they might benefit from or they might be on, and how that affects our care. Because yeah, I remember I forgot that part and wanting to bring that in, and of how I would go that into the initial assessment, because that also potentially is like, do I offer sliding scale? What does that look like in terms of payment? Are they, having to figure out with them like what they can afford per month to pay for me, right? If they're on SNAP, indicates to me obviously that they are a certain income level, and so all of these things kind of play a role into, I think, even their comfortability of like coming to me being like, okay, are we doing sliding scale? I saw that you're on SNAP benefits, instead of waiting for them to have to ask, because I think obviously there can be some shame in that as well, or not even saying sliding scale, like, you know what I mean, like, I think it depends. Obviously my rates are on my website, but I think sometimes I'm like, well, what do you imagine paying me, opposed to me giving them the number, which I know varies.
Yeah. I think this was all super great stuff to kind of orient us to, like, clearly a intake or assessment does not end at the first visit. Like, it is an ongoing process of learning and digging deeper and really finding out everything we can about the person coming to us for support. But we are going to make sure that we, as we're developing the series out, we also come to you with what the next stages look like, where it takes us past the assessment and intake, and how we can expect to work with the client to help support them along the way. So thanks so much, everyone, for joining us for that quick intro on what happens when we get a new client and how we're dissecting their case on an individual basis. And hopefully we tune in next time to just take you along the journey and see what happens. Bye.